Well, thank you very much for joining me today for episode 11 of season 2 of the Healthy Skeptic MD podcast. I'm Dr. Michael Hockman. So far in this second season of the Healthy Skeptic MD, we have covered a wide array of health topics, everything from cancer screening to ear tubes in children. We're going to conclude the focus of season 2 next week with a discussion of dietary supplements with Dr. Peter Cohen. But today we're going to take a bit of a tangent and discuss health policy with two of the best-known advocates of a single-payer national health insurance program. That's Drs. David Himmelstein and Steffie Woolhandler from Hunter College in New York. Now, some may dismiss the idea of a national health insurance program due to concerns and skepticism about big government. And I certainly do understand this concern, having myself worked at public health systems at various times throughout my career. But to be clear, the vision that David and Steffie are going to describe today is not of a government-run health system, but rather of a publicly administered health insurance system that would be much simpler for doctors and patients alike and would make sure that everyone has coverage. And David and Steffie are going to describe exactly what they mean by this in the interview. Regardless of what your views are on this topic, David and Steffie provide really important insights on the health system. For what it's worth, I do agree with their ultimate conclusion, but I know not everyone will. And it's a really good discussion, so do stick around for it. Okay, so before we jump into today's interview, as always, let's do a rundown of the health news of the week. So I first want to start with a study in JAMA Internal Medicine on the overall performance of the U.S. healthcare system. So it's widely known that we Americans do not live as long as our counterparts in many other parts of the world. And this is often attributed to high rates of poverty and other social challenges that lower income residents in the U.S. do experience. But this new study challenges this assumption or this conclusion. So it found that if you look specifically at wealthy white Americans, even in this group, we do not do as well as average residents of other parts of the world. So for example, maternal mortality rates among wealthy white women are actually higher than among average income women in other parts of the world. And despite all the technologies that we have for treating heart disease here in the United States, heart attack death rates for wealthy white individuals are actually no better than they are in other parts of the world. So there's many explanations for these findings, but what it tells me is that all these fancy, expensive technologies we have here in the United States do not frequently translate into better health, which of course is one of the key themes of the Healthy Skeptic MD podcast. So the second news item I want to touch on is another study in JAMA Internal Medicine showing the value of mindfulness meditation. So the study specifically looked at improvements, or demonstrated, I should say, improvements in quality of life and depression among migraine sufferers who did mindfulness meditation. I'm a big believer in the mind-body connection, and I often do recommend meditation for my patients, so it is nice to have some rigorous supporting evidence to show the value of meditation for migraine sufferers. So the final news item I want to touch on is a JAMA study looking at the problem of overuse of medications in older adults, which I think many of us know to be a problem. But there was truly an eye-catching statistic, at least to me, in this JAMA study. So it reported that among older adults with dementia, 14% are on not one, not two, but 3 or more medications that adversely affect brain function. That is a lot of medication. So this is just yet another reminder that if you have a loved one with dementia, it is so important to go over that medication list with their doctor just to make sure that all those medications truly are necessary, or that it's not possible to at least lower the dose of some of those medications. So that's it for the news summary. Let's jump into our interview with David Himmelstein and Steffie Woolhandler. Well, welcome to the Healthy Skeptic MD, David and Steffie.
Thanks for having us.
Okay, so you are now both distinguished professors at Hunter College in New York. So tell us a little bit about your current work.
Well, we do teaching for master's students and undergraduates, but most of our time is spent continuing our research on access to medical care and the intersection of social problems and health problems in the United States. We're also still on the faculty at Harvard Medical School, where we, for many years, taught research methods and internal medicine.
And until the pandemic, we were actually helping to supervise the residents at a clinic in the South Bronx. Because of our ages, they told us we probably should halt that until things got a little bit safer, but we plan to go back to that.
That's right. And I know you've had years of being primary care doctors, and that probably drives a lot of your interest in this topic. I know that from being a resident caring for your patients during my medical training. As I understand it, you're now in the Berkshires during the pandemic. You're working virtually.
Yes, we're actually a couple of hours north of New York City, and it's very snowy, but very pretty up here.
Good. Well, I'm glad you're staying safe during this. So I think it's fair to say that you really have been the national leaders in advocating for single-payer national health insurance over the last several decades. Let's start at a very basic level. What do you mean by a single-payer national health insurance system?
Well, single payer is what used to be called national health insurance, and basically government collects the money for health care out of taxes and pays the bills, is the insurer for everyone in the country. So it would provide universal, comprehensive coverage for everybody living in the United States for everything that they needed for medical care, and would replace the current Medicare and Medicaid programs and private insurance and uninsured with a single publicly administered payment program.
And when people hear the term single payer, sometimes people think of the VA medical system or a government delivered healthcare system. Is that what you mean here, or is there a distinction?
Okay, well, the VA is certainly one type of single payer system, but the traditional Medicare program that people are familiar with for seniors, where you pay your taxes and then the government pays the bills for your doctors and hospitals, that is also a model of a single payer system. Now, the single payer system we're advocating would be like a Medicare for all and an improved Medicare that did not have copayments or deductibles for covered services.
So doctors would remain in private practice or employed in clinics, private clinics or publicly owned clinics. Hospitals would remain in largely private hands, mostly nonprofit private hospitals, some public hospitals, but government would pay the bills, not own the hospitals or clinics, and not directly employ the doctors or nurses as the VA does.
And I know you would advocate for some differences with the Canadian system, but if you were looking for an analogy, is it fair to say that the Canadian system is most similar to what you're advocating?
Well, the Canadian system, which they actually call Medicare, they use the same name, does provide complete free access to doctor services and to hospital services for everyone in Canada, and it has no co-payments or deductibles for what it covers. The problem with Canada is it does an incomplete job covering pharmaceuticals, and does an incomplete job covering long-term care. And of course, people need those services as well. And we would like to see a Medicare for all single payer program that extended to all medically needed care, including medications and long-term care. But Canada, at least for their doctor care and their hospital care, you can go to any doctor, any hospital in Canada. And if you're a Canadian, there's no co-payments, no deductibles for that care. You take nothing out of your pocket other than your card, your insurance card, when it's time to get medical care.
And that's pretty much the model that we've suggested should be adopted in the United States.
How did you come to the belief over the years that a single-payer national health insurance system is the right system for the United States?
Well, we never intended to get involved in health policy and health financing issues. Really, starting back when we were residents many years ago, we planned to be full-time clinicians and found that the healthcare system just wouldn't let us take care of our patients the way we wanted to them and the way we thought they deserved. Many of our patients couldn't afford care that they needed. Many were uninsured. We were, during residency, working at the public hospital in Oakland, California, a lot of uninsured people, and many of them were being refused care at well-resourced private hospitals and instead had to resort to the care at the public hospital, which was terribly under-resourced at the time. So we began to look around at what might be the solution to the problems we were seeing. And we saw, first of all, that there were adequate resources in the community as a whole. If you looked around Oakland and Berkeley, California, there were lots of hospitals, lots of doctors, but our patients couldn't get access to them. And there was enormous waste in the healthcare system. Many patients who were not ours, but were cared for at the private hospitals, were getting care that was either useless or sometimes even harmful, excessive care. And at the same time, our patients couldn't get the care they needed. And there was a tremendous administrative and bureaucratic waste because of the complexity of the financing system and the need to sort people into different categories of who was had the right to what kinds of care. So we looked around at what kind of models there were and what comparisons we could make between the U.S. and healthcare systems elsewhere. And actually, when we moved to Boston, Steffie signed up to teach a course at the Boston University School of Public Health on healthcare systems in other nations, and really began investigating how things worked elsewhere. So we learned during that period a great deal about the Canadian system and began comparing it to the U.S. and the ways in which it would really offer a solution to many of our problems, both getting the resources to the patients who need them and eliminating a lot of the bureaucracy that took the resources that we needed for clinical care and also was really maddening for both patients and doctors.
So it really grew out of your own personal experiences as practicing clinicians. And David, I remember there was a story you used to tell about taking patients from nursing homes who came in severely dehydrated that had a big influence on you. Could you tell us a little bit about that?
Yeah, so when I was an intern, actually, we admitted to the hospital a patient who eventually died from his dehydration. He was so dehydrated. He'd come from a nursing home, and my resident and I decided we wanted to look into the kinds of dehydration that we were seeing at that hospital. And we pulled the charts of all of the severely dehydrated patients that had been admitted over the past year and found that one nursing home was responsible for the vast majority of those patients, and really looked into what was behind it. And what we concluded was this was a for-profit nursing home, part of a large for-profit chain that was economizing, or really not just economizing, but cutting barely below the bone on the care of these patients. And the patients just were getting completely inadequate care. They didn't have the nurses that were needed, or the dietary personnel, food personnel. And that kind of led us to look more broadly at the influence of profit making in the healthcare system, and to see that the influence of profit making was really pernicious, not just in the nursing home industry, but in other parts of the system as well. And we've done research on that in more recent years.
Right, and commercial influence and profit are, one of the things that probably drive part of the solution here. We'll come back to that a little bit in a moment. But we do not currently have a national single-payer health insurance system. We have a complex mishmash of private insurance that's administered through employers and through other programs. Steffie, how would you describe our current healthcare system and what's wrong with it?
Well, it's chaotic. It's fragmented and it's profit-oriented. So it means that we have 30 million people with no health insurance, but we do have tens of millions more who have health insurance they can't afford to use because they have co-payments, deductibles, uncovered services, that when they get really sick means they have to take literally thousands of dollars out of their pockets to pay for care. And we have put profit making in healthcare as a major part of our healthcare system, and that's something that other countries do not do. They believe that the healthcare system should be organized as a public service on a nonprofit basis. A few of them do a little for-profit stuff, but nobody nobody has organized the healthcare system so thoroughly around the rights of people to make profits off of illness. So we need to be thinking about organizing our healthcare system on a fully nonprofit basis, on the idea that healthcare is a public service and that you should not be profiteering off of sick people. And, that's a decision other countries have made, and we need to be making that same decision here in the U.S.
And we need to simplify the system. So even for people who are well versed in the health financing like us, we have trouble figuring out, for instance, which insurance plan is going to be the best. And when our kids move to a new city and ask for our input on what insurance they should take, we were at a loss, frankly. We read the fine print and we couldn't figure it out. So we're expecting tens of millions of Americans to sort through the fine print on insurance contracts and the papers they give you at hospitals about what financing you're responsible to. And people can't do that, especially when they're sick.
Well, that's one of my biggest headaches every day as a doctor. A patient comes in and they have health insurance plan X and what medications are on their formulary and what's their copay and deductible and which specialist can I send them to, and amplify that times 10 if you're the patient and less savvy on these issues. I can't even figure it out as someone who does this on a day-to-day basis. And that's a direct result of the fact that we have multiple different payers, each with their own sets of rules and their own corporate goals that are being
right. And if you get it wrong and the patient gets it wrong, then it's extremely expensive. The patient goes to pick up their medicine at the pharmacy and there's a $200 copayment. The problem with that is it's expensive, and maybe the patient doesn't go back the next month to get those prescriptions.
Well, I always tell our students here at USC that we have a medical campus, and the proportion of buildings that are dedicated to administrators has grown just exponentially over the last several years that I've been at USC, so much faster than the clinic space, because it's only getting more and more complicated to deal with all the billing that needs to happen. Let's go back to 2009. The Obama administration passed the Affordable Care Act. That was an expansion of health insurance. Since then, the rate of uninsurance in the United States has dropped from about 18% to about 10%. That's a good thing. But why is that not the ultimate solution? Why don't we just keep doubling down on the Obamacare approach?
Well, a couple of things. One is, as Steffie mentioned, there are still 30 million people who are uninsured. And not just that, but underinsurance is incredibly common. Tens of millions have coverage, but they still can't afford care. And we've actually done a fair amount of research on that at several studies with a then Harvard colleague, Elizabeth Warren, looking at bankruptcy, for instance, and finding that about 60% of all personal bankruptcies at this point involve a medical bill or an illness as a major contributor. So most of those people who are medically bankrupt actually had coverage, at least when they first got sick. So one thing is that we've not really approached universal coverage and certainly not approached comprehensive coverage. But beyond that, moving forward with the Obamacare approach is extremely expensive. So we spend about twice per person what they do in Canada on healthcare in this country. And if we were going to add coverage for the uninsured and address the underinsured, we'd bump our health spending up even higher. And the estimate is that getting to universal coverage under a multi-payer system would cost something like $650 billion a year more than doing that with a single payer system, because a multi-payer system wouldn't get the bureaucracy and the billing costs and the doctor's time spent on the needless administrative tasks out of the system. So moving forward with Obamacare is extremely expensive compared to a single payer approach. And for that reason, we think it's actually not viable to get to universal coverage with a non-single payer approach.
Okay, so I think most people would agree there'd be advantages of a single payer system. It would ensure everyone is covered. It would be a heck of a lot simpler. But many worry that there'd be downsides of a single payer system. A government controlled system, maybe there wouldn't be any recourse for patients or doctors. There's no other games in town if a coverage decision that you don't agree with is made, or if you don't get your claim paid if you're a doctor. What do you think the downsides would be of a single payer system?
People all over the world have systems like this, and generally they're pretty happy with them. Like the satisfaction with the healthcare system is higher in other wealthy nations than it is in the U.S. So this supposed downside that all of the doctors and hospitals are going to be engaged in this single system has not turned out to be much of a downside overall. I think there are some issues, like we have with the Medicare program. There's a panel that makes a decision about whether something's covered by Medicare. Some people aren't very happy with that decision, but in most cases, people find that most of what they need, did get included in the Medicare coverage.
Yeah, I think, for my part, I'm reluctant to trust the government, and I think our experience during the Trump administration is a cautionary one. And frankly, I have the FBI file to prove that I do distrust the government. But given the choice between a private insurance company making the decisions, whose decisions I really don't have any say over, I have no right to vote on them. I can't even attend their meetings or hear what they're saying at their meetings. Given that, I'm much happier to say let's put it in government hands than trust the private insurance industry to make the decisions about my health care.
Right, and I've always never fully understood the argument that we have so much recourse in our current system. If a private insurance company denies a medication that I want to prescribe, there's still nothing I can do about it. That patient can't switch to a different health plan until the following year, at which point it's too late. And if a claim is denied...
Right. Well, it's exactly the same issue. If it's not covered, now you have the recourse of just taking thousands of dollars out of your pocket and paying on your own. That recourse would still be there at the single payer, but as I said, hopefully be less of an issue because 100% of doctors and hospitals are likely to participate. Let me say at least 100% of hospitals, high share of the doctors are likely to participate.
I do want to come back to that point you made about government and efficiency. I've spent a lot of time working locally within the LA County system. It is not exactly the model of efficiency. But you've done some research that has suggested that as inefficient as government can be at times, actually in terms of administering healthcare, it may be doing better than the private sector. In particular, I'm talking about a 2003 paper you wrote in the New England Journal. Could you tell us a little bit about what that study showed?
It is possible to measure directly how much is going to administrative costs in public institutions and private institutions that provide health care. And it's very clear that the public sector is more efficient. It spends a much smaller share of total dollars on administration. So if you look at the traditional Medicare program, where you pay your taxes and the government pays your medical bills through Medicare, right? The overhead on that program is only 2%. 98% of all the spending goes for the actual medical care. If you look at private insurance industry, the average overhead is like 13%, meaning only 87 cents of every healthcare dollar is actually going for healthcare. So that's the data. I know you're right. We've all had this experience in the DMV or something. It seems so inefficient. But the data on healthcare is that it is much more efficient to administer a universal public program.
Yeah, and it's frankly not just our research. I was happy to see the Congressional Budget Office came out with a report in December estimating the costs of implementing a single-payer program in the U.S., and they concluded that the administrative savings from single-payer would be so large that you could cover everybody with first-dollar coverage while actually cutting the costs of the healthcare system, because you would save so much on insurance overhead and other administrative burdens. So we're happy to claim that we were early to make that observation, but I'm also happy to say that the Congressional Budget Office agrees with us.
Right. And just to be clear, that administrative waste is both on the insurance side, all the administration that goes on that side, but also on the doctor side, all the complexity of dealing with all the different rules and regulations of each health plan. If you had to give an estimate, what percentage of healthcare is just administrative waste that could be eliminated with a single payer system?
Well, we have generated some estimates from the data, probably around 17%. If we look at the share that's spent on administration in the U.S., which is about 34%, and compare it to the share spent in Canada on administration, about 17%. It's a 17% difference, 17% of total U.S. health spending. U.S. is spending $3.5 trillion every year on healthcare. So 17% of that number wasted on administration is a very, very large amount of waste.
And we should, as you pointed out, Michael, that includes not just the overhead of insurance companies that we could eliminate, but a lot of the waste of time and money of doctors and nurses and clerks in the healthcare system. So our estimate is we have probably about 1 million people doing useless bureaucratic work in the healthcare system in the U.S. And a couple of recent studies have, for instance, looked at how much time doctors spend inputting data to the electronic health records related to finance and billing. And we'd save enormous amounts of doctors' time. If you look the same electronic medical record in Canada and the U.S., the doctors in Canada have about half the time that we spend entering the data in the electronic medical record.
And to be clear, some of that electronic health record work that we're doing as doctors is documenting clinical findings, which is important. But 50% or more, I would estimate, of my time in there is setting things up for billing purposes, which is really not added value from the patient perspective. So, Steffie and David, President Obama famously said that if he were starting from scratch, single payer would be a no-brainer. It's the simplest, most efficient system, but we're not starting from scratch. We have a big health insurance industry. There's a lot of people whose jobs depend on the current existing system. It's just not practical at this point to make a shift. Is there some truth to that it would just be logistically incredibly difficult at this point to totally shift our approach to health insurance?
Would it be logistically difficult? No, because we already did a major transition from what existed before 1966 to the Medicare program in 1966. And the transition took less than a year, and it worked pretty well. So technically, you can do the transition. The question is, politically, can you do the transition? And the private insurance industry is making a lot of money, and they're not going to want to give up their health insurance business easily, and they are going to fight us at every turn. Frankly, the pharmaceutical industry is very reluctant to deal with a single payer because they think that the single payer will force them to bring down their prices and put them in line with the prices in the rest of the world, which is about half what American patients pay.
And again, the concern there is that the government could negotiate better rates similar to what other countries pay for their
Absolutely.
drugs.
So they are politically opposed, and that I just think we're going to have to fight with them about. I do want to talk about the million or so people who do work for the private health insurance industry. It's obviously not their fault that the system is in this kind of shape, and what you need to do for them is have a transition program that supports their income, supports their retraining, perhaps supports redeployment into clinical services. You know, the kind of thing you did that was done in the United States after World War II, where we had to reintegrate millions of young men back into the U.S. economy. And when they finished their service. So we gave them money to go to school and financial support through the GI Bill. So we know how to do that, and it would be much cheaper to spend the money that way than to continue to waste 17% of total health spending on these excess administrative costs that we were talking about.
And just for that reason, the single payer bills that are in the House and Senate actually call for several tens of billions of dollars to be devoted to a transition program for the displaced workforce. Now, we wouldn't be able to find comparable job for the CEO of an insurance company making $40 million a year, but mostly we're talking about low-paid clerical workers, and frankly, we ought to be able to find useful work for them at decent wages.
Yeah, I remember you used to joke, David and Steffie, that you always wanted to cover for these insurance company executives on the weekends. Get a couple $100,000 for 2 days of work.
One of our favorites was a former Harvard colleague. You may remember him when you were at Harvard, Jack Rowe, who used to be the chief of geriatrics at Harvard, and he went to Aetna, and he was CEO at Aetna, and during his time there, he made $225,000 per day. So we like to joke that we wouldn't be able to find Jack comparable wages elsewhere.
Right. Cover for him for one long weekend, and you'd have a pretty good year. Well, I think that is a really important point, because there are a million jobs is a lot of jobs, and you definitely have to be thoughtful about a transition so that people aren't hurt as a result of that. Well, Steffie and David, I have one final question for you. We're in the middle of a pandemic right now. How has the situation we're dealing with COVID-19 influenced or affected your thinking about single payer? Has it further strengthened your beliefs? Has it raised any concerns?
It does really underline that people need care. They need access to care when they need it without having to worry about financial repercussions. It's also a reminder that we're all in this together. If COVID is just rampaging through poor communities, minority communities, we're all going to be affected. It's not going to stay just with low income and minority people. And to optimize the health of the American people, we need to make sure everyone has timely access to medical care.
Yeah, I think the pandemic has really emphasized a few things that are both concerning and maybe hopeful in some ways. One is that the financial problems that a lot of medical providers have encountered because patients other than COVID patients weren't coming in for care has really opened the way for venture capital firms to buy up an increasing share of doctors' practices and even hospitals. So I think we're likely to see a surge in for-profit ownership of the healthcare system, and I think that's very disturbing. A second is that it's really made clear how fragile our private health insurance network is, because many people have lost their jobs and with it their health insurance at a time when they've needed it most. So in that way, it's maybe strengthened the case for national health insurance, and I think made people more aware that we need a strong government program in times of crisis. So we've weakened not just coverage through the years, but the public health workforce in the U.S. has really deteriorated going back to the year 2000, not just under President Trump. So I think the pandemic has underlined the importance of having a government that's ready to function in the healthcare sector. And for me, one of the things that the pandemic has really also highlighted is how connected we are to the rest of the world, and that we have responsibilities in global health that we need to take much more seriously. So frankly, solving the healthcare problems in the U.S. is fairly simple. We're spending enough to do the job now if we just did a rational healthcare financing system, but we also need to pay attention to the needs of the rest of the world. If COVID is rampant in poor countries, we're going to be developing variants that are resistant to whatever drugs and vaccines we develop. So even for our own self-interest, let alone the moral case to be made. We need to be trying to address the global health inequalities that are so stark. So to me, those are some of the lessons of the current period.
Yeah, well, I agree with you completely. Two things that's really struck for me is how tenuous it is when people rely on their jobs for health insurance, because so many jobs have been lost, as you said, during this pandemic. And the last thing you need when you lose your job is to lose your health insurance too. The second thing is just the complexity. The government has not performed perfectly during this, but the fact that the system is so complex, where you have private insurance and Medicare and Medicaid all with their own rules and policies, and the right hand is not talking to the left hand, I think has just exacerbated a very difficult situation. So the added simplicity of a single payer system just really, that really drove it home for me.
I think one of the experiences many people have had is, it's time to go in for your vaccine, and you want to get into that clinic and out of that clinic as fast as possible so you don't get any exposure there. And yet, after you get your vaccine, they ask you to pull out an insurance card and to start entering insurance information.
It's a really interesting point. I think it's been widely quoted that the vaccine is free, and the vaccine itself is free, but there's been administrative fees that have been charged that add an incredible extra layer of complexity. And as you said, what we want to do is expedite the vaccine, make it as simple as possible to get it to people as quickly as possible. And that really is just another hurdle that we need to deal with. And that's what we do every day, hundreds of times per day with every patient, every time they come in for care. Well, Steffie and David, I so appreciate your joining us today. Healthcare is a complex topic. Not everyone is going to agree, but I think the things that I think we all take away is that a single payer system would clearly ensure everyone gets covered in an equitable way, and would do it in a much simpler system. So thanks for joining me today. If you enjoyed what you heard today, please search and subscribe for the Healthy Skeptic MD wherever you listen to podcasts. Pass it along to friends, family, and colleagues, and give us a review if you have a chance. And stay safe in the Berkshires, Steffie and David.
Okay, you stay safe in Los Angeles.
Thanks so much, Michael.
Yeah.